Hello everyone, my name is Dr. Mucheru Wang'ombe. I'm a consultant psychiatrist at Mathari National Teaching and Referral Hospital, and I'm pleased to share with you information about bipolar mood disorder. Of note is that we are celebrating the World Bipolar Day 2025 on the 30th of March this year, and the theme is bipolar strong or bipolar together. What bipolar mood disorder day is all about. The day was first celebrated in 2014, and the choice of March 30th was made to coincide with the birthday of one of the artists, a Dutch artist called Vincent van Gogh, who was diagnosed with bipolar posthumously. And this year, we are raising awareness. We want to educate, empower, and help each of us understand how we can diagnose bipolar and related disorders, support those living with bipolar, and reduce the stigma of seeking treatment. Bipolar and related disorders is a classification by the Diagnostic Statistical Manual for Mental Diseases, version 5, what we call DSM-5, and ICD-11 classification is bipolar affective disorder. Why bipolar? There are two poles. So there is oscillation between extremes of mood. There are the highs and the lows of bipolar. That is why World Bipolar Day is marked with a white and black ribbon. The white represents the high of bipolar, the black represents the lows, and the waxing and waning nature of this condition is represented by the stripes. What do I mean by waxing and waning? The bipolar and related disorders are episodic. So they are a cluster of symptoms that occur within a certain duration of time, after which, when the patient gets treatment, then the symptoms abate and the patient is able to live a normal life. So we have various disorders under that classification, and we have bipolar 1, where you need at least one manic episode, whether past or present, or a mixed episode, where a mixed episode means both symptoms of mania and depression present when it comes to the ICD-11 classification. So we are saying that bipolar 1, you need a manic episode in the past or in the present to make a diagnosis. Bipolar 2, they are hypomanic episodes, meaning the symptoms do not meet the criteria of a manic episode. And what brings the patients to hospital is depression. When a patient has mania, they do not have psychotic features. So they may not be grandiose, they may not feel more important than they actually are, or they may not have any hallucinations. For example, hearing voices that tell them how great they are or how rich they are and how they're the best of the best. They won't have that when it comes to hypomania, but in mania they have. So just to shed some light, I would like to talk about the symptoms of a manic episode. Patients have this elevated, expansive, or irritable mood, plus other symptoms like distractibility, impulsivity. So they will do stuff that involves risk-taking, whether financial or otherwise. So that is when they will spend all their money, they will dish out all their money, or they may engage in other risky behavior, which then makes them dysfunctional. They become grandiose, so they feel greater than they should be. They present with flight of ideas, where they have many ideas. They're having racing thoughts. So they'll talk about this idea. Before they finish, they have started another idea. Before they finish, there is another one. They also have a lot of activity, goal-directed activities. Let me give an example. If somebody is cleaning, they will clean all night and all day, and they will continue cleaning. If they are walking, they will walk, for example, from Nairobi, they'll walk far distances. These are goal-directed activities, but now they are done in excess. They suffer from a sleep deficit. They have decreased need for sleep, and they tend to be over-talkative. That's a manic episode. What about those who are depressed, like in the case of bipolar 2, where they present with depression? This person has sadness, which spans over at least 2 weeks, every day, nearly every day, for a minimum duration of 2 weeks. They also have trouble when it comes to sleeping. So the sleep is disturbed. They might either sleep too much or sleep too little. They would have lack of interest in pleasurable activities. Somebody who enjoyed watching TV now doesn't enjoy watching TV. They were good at playing golf. Now they don't want to play golf anymore. They feel guilty. They feel worthless. They suffer from low self-esteem. Their energy levels dwindle, so that the person may struggle to get out of bed in the morning, to take a shower. They may actually struggle to even brush their teeth. So their energy levels are low. In addition to that, their concentration is rather poor. So they will want to make decisions. They're having trouble with forgetfulness. They want to make decisions. They're not able to make simple decisions, whether to cook or not to cook, to eat or not to eat. In addition to that, they have psychomotor retardation. So they tend to walk slowly, do things very slowly, as if they're in slow motion, not because they want, but because they have no energy. They do tend to have suicidal thoughts. Sometimes they attempt suicide, sometimes they are planning to harm themselves, and in the unfortunate event, sometimes we end up with completed suicide. So we've talked about bipolar 1, which needs a duration of a week of symptoms, or any duration, including 1 day if the patient required hospitalization. Bipolar 2, the hypomanic episodes, they need to last for at least 4 days for a diagnosis. We then go to cyclothymia, which is a milder form, I would say, of bipolar 2, where the patient presents with depressed episodes and hypomanic episodes, but these ones do not meet the threshold for diagnosis with bipolar 2 disorder. That is cyclothymia. These symptoms persist for a period of 2 years, and you can't count more than 2 months in between in those 2 years when the patient has been without symptoms. So that is cyclothymia. We then go to other specified bipolar and related disorder, where these are symptoms. The symptoms are described either of mania or depression, but are subthreshold. They don't meet the criteria for bipolar 1, bipolar 2, or cyclothymia. We have bipolar and related disorder secondary to medical conditions. You may have medical conditions, especially those that have manifest with high steroids, like, for example, Cushing syndrome, which would manifest as somebody with the manic symptoms, depressive symptoms, and they are classified as bipolar and related disorder, secondary to a medical condition. We also have substance-induced bipolar and related mood disorder. The number one culprit is alcohol. Number two is cocaine. Then our very own antidepressants. If a patient has a depressive episode, probably they have bipolar 2, which has not been diagnosed, then you give them an antidepressant, it can induce mania. So that is what we are calling medication, substance-induced or medication-induced bipolar related disorder. We also have unspecified bipolar-related disorder. This refers to a patient who presents to an outpatient setting, probably with acute agitation. We don't have a lot of information about their history. We don't have any other symptoms other than just the acute agitation. Then unspecified bipolar disorder diagnosis can be made. How do we treat bipolar mood disorder? One, it's important to be evaluated by a qualified mental health professional. But that does not mean you can't screen yourself with an online tool to find out, could I be suffering from bipolar 1 mood disorder, mania? There is a mood disorder questionnaire which has 15 items, which you can use to screen yourself. But for the ultimate diagnosis, for investigations to rule out medical causes, to rule out any brain pathology, you would need to be evaluated by a qualified mental health professional. Then, in addition to the fact that you can screen yourself for mania, you can also screen yourself for depression. So, a Beck's Depression Inventory is a 21-question questionnaire which can be completed, and you get to know the scores. Patient health questionnaire is also another one that you can use to screen yourself. But remember, once you have screened yourself and it is indicative that you may need further evaluation, kindly seek help, and seek help fast. So, going to treatment, we have various forms of treatment. We have medications which help with stabilizing the symptoms that either of mania or depression, whether they are acute or it's in the maintenance phase. We also have psychotherapies. We psychodicate patients, meaning by psychotherapy, I mean talk therapies. So we work with psychologists to make sure that patients are psychoeducated. There are family focus groups, there is peer support. All those are useful when it comes to treatment of bipolar and related disorders. We also have the role of support groups. Support groups are by the patients themselves. People with a certain diagnosis, people living with a certain disorder come together and they're able to discuss among themselves about their symptoms, how they are coping, and they encourage one another. And this helps them to have a sense of belonging. So then they also are, they're out looking out for each other, finding out so and so who is posting on the group is now talking of being president when in fact we don't know they are president. Or they are now dishing out money, or they have been seen somewhere and they are not in a very good state. They are then brought to hospital. So when it comes to the community, we need to embrace the fact that anyone suffering from bipolar mood disorder or living with bipolar needs support. So we need to make sure that the public are aware that bipolar and related disorders are amongst us. We are at risk. And speaking about the risk, the global prevalence of bipolar mood disorder is about 1 to 2%. And it is estimated that bipolar is the sixth leading cause of disability worldwide. So that tells us that this is a condition, or this is a group of conditions that we need to be aware of. We need to identify early, make sure patients are treated, and that we make sure that they are well supported to continue on treatment. Now, what would make someone with bipolar and related disorders relapse or have a recurrence of symptoms? Stress. Stress is one of the biggest contributors. Stress can be an entry event. It can be the birth of a new baby. It can be a promotion to CS of this country. It can be a jackpot. You may have a windfall, maybe a salary raise, or you have won a lottery or something. It can trigger an episode. On the other hand, exit events. If you lost your job, or you lost a loved one, or you lost property, then that can actually trigger an episode, both the initial episode and subsequent episodes. Substance use. When I talked about substance or medication-induced bipolar and related disorder, substances not restricted to alcohol and cocaine, other substances also can contribute to mood symptoms and psychotic features, which can then make it more difficult even for the patient who is on treatment to realize any improvement. Then there's the genetic aspect, and the genetic aspect, there is what is called epigenetics, such that our behavior can influence the expression of genes. It will not affect the expression of the, it will not affect the sequencing of the DNA, but it can affect the expression. It is something that is reversible. But some of those are risk factors. Childhood trauma, adverse childhood events. Please protect our children from situations where people are physically violent, where their parents are going to prison, where there is somebody who is mentally ill and not managed well in the family, or where there is fighting or being bullied even in school. So that also brings us to the fact that school programs are also important when it comes to preventing these mental health conditions. We are open as Mathari National Teaching and Referral Hospital to evaluate patients, those who have screened themselves, those who haven't been screened, anybody who has had this talk and feels they may need some help, or their loved one may be suffering from bipolar and related disorder, or probably may be undergoing a life situation that is difficult. We have psychiatrists, we have psychologists, we have an outpatient department that is open 24 hours, which is open to give services. We have specific clinics We have psychotherapy clinics on Thursdays run by psychologists who will look into the plight of anyone who may need to discuss a life issue, something that is stressing them, any life changes that somebody is having trouble adjusting to. We also have the Center for Substance Abuse Treatment called CSAT. It happens every Tuesday, run by psychologists, where patients with substance use disorders are attended to. We have a drug rehabilitation center that is residential, and we are open to the public for people to come and get help with substance use disorders. In addition to that, we see children and adolescents on Wednesdays. So there is a child and adolescent clinic running every Wednesday at the facility, and it would be our pleasure to serve you and to make sure that we have a healthy community and that we make an impact when it comes to mental wellness, so mental health promotion, and when it comes to treatment, prompt treatment, follow-up, and also welcome to our open days. World Suicide Prevention Day on September the 10th every year, World Mental Health Day on 10th of October every year. Please feel welcome. Thank you.